Does it work? Yeah. So then we're very happy to introduce Fola. Actually, as Michiel was already saying, Fola is our special guest. Fola is the managing director of Hygeia and of the community insurance program of Hygeia. And I can emphasize that without Hygeia, we would never have gotten so far as we did. Because after all, from 2000, PharmAccess has been in touch with Hygeia since 2004, 5, maybe even longer. But anyhow, the whole concept and to start on with this very program, I think it's very much also thanks to Hygeia and to Prof that we came up with this visionary new concept.
Right. And Prof is the father of Fola. Otherwise, you know, otherwise we say Prof. And Prof is the wife of Prof. So the mother of Fola.
Well, thank you, Kees and Alge. Unfortunately, I'm not a prof. But, well, thank you. And thank you very much to you for inviting me to be part of this really, really, great occasion in honor of Honor and Max. I will, very much focus on the community health insurance program that we've been working on with the Health Insurance Fund. But maybe just before that, just tell you a few things about Hygeia, because if I could say so, I would hope that we will be considered at some point in time as very much a proof of concept to everything that we've listened to about the PharmAccess family. Because across the board, we have worked with PharmAccess in so many ways that has been catalytic to the growth of our own organization across the different angles. We started very much as a hospital company, running the Lagoon hospitals, which is what my parents founded. But since then, through the PharmAccess system, we have, obviously with IFA, the IFHA, they have been extremely catalytic in helping us unlock the business case for investment in healthcare facilities in our part of the world. And I would say that we have been able to unlock something in the region of $25 to $30 million since IFA came on board, both in terms of equity, private equity, and debt. And of course, if I also talk a bit more as I go on about the community schemes and some of the other foundation work we've done, they've also been catalytic in helping us sort of unlock the access to about another $10, $15 million. And that's been significant given the discussions that we've had all day today about the severe underfinancing of health in Africa. Being able to showcase ourselves and work with a partner like PharmAccess obviously has been extremely instrumental on that side. Similarly, even when we talk about quality, Lagoon itself was also going very much on the track of investing in quality systems and has now become the first hospital group to obtain JCI accreditation in Africa. And that, of course, has also brought us in very close collaboration with COSASA and PharmAccess and the Safe Care Initiative. So as you can see, we work very much, and as I said, hopefully we will be, history will write that we were the proof of concept very much for everything PharmAccess set out to do. If I then sort of focus specifically on the community insurance plan, we got going with the Health Insurance Fund and PharmAccess very early on in the thinking and in the visioning for the program. And essentially realizing that, again, the story of access to healthcare, whilst we had already sort of launched into it on our own on a more formal private health insurance scheme for corporates and for commercial groups, it was going to be difficult for probably 70% of the population of the country to ever have access through those means. And therefore, alternative routes of being able to create that access for low-income communities was key. And that was essentially what made, the visions of both sides meet. And obviously with the funding, the catalytic funding of the government, with Alge's very, very able support, the World Bank, and I know Dirk is here, and I'm sure Dirk will probably remember the very early role that he played in all of that as well. And of course, the Kwara State government itself as showing that a local government could also be a willing and able participant. And all of that, had to come together for us to really be able to provide a program which is today now looking after just over 90,000 people. For us, we learned many, many, many lessons along the way, I must say, and we're still learning. But I think what has been key for us is realizing that there's a platform which was very much the managed care health insurance type of platform, but which had to have, some key pillars, 4 legs to the table, as it were. Financing the subsidy. I know some discussions have been had about sustainability and so on and so forth, but we couldn't do this. We still can't do this without some kind of financing mechanism, because these are groups who cannot afford to do it on their own. And yes, there's a lot of debate about whether it's the role of the donors or whether it's the role of central government or local governments or combination that has to take on that on a sustainable basis. But at least it was very much, it's a fact now that has come into thinking after we started this program, very much on our central government's sort of viewpoint as well, that it's key that the subsidy is financed, because otherwise the appropriate package of health is not put on the table for the people. The provider systems, and I think that's very much closely linked to the quality systems of how do you make sure that the supply side has the infrastructure, the skills, and the overall support that it needs to, again, allow the demand side to trust it and to use it. And then, of course, the demand side itself, which, again, we've heard very much about insurance and, obviously seeing what has been the trend and how it's been built over almost 200 years here in Europe. And obviously, we're just getting started in Africa, and there's a lot of work that still needs to be done in terms of the awareness, the adoption, the acceptance. And of course, we mustn't forget that part and parcel of that is the community administration, but really ownership. We've got to get the people themselves to feel very much in control. I'll just try and skip some slides because I know that we're short of time, but this is really just trying to show the managed care platform, which is a platform that goes from the one end of the scale of a financing system and at the other end of the scale, a delivery system, all very much in one platform. And one of the key reasons why this platform has been adopted has been that it would create much more efficiencies in terms of the resource poor setting in which we operate. Our benefit package is a pretty robust one, very much along the lines of WHO's standards of a minimum package, very much in conformity with our own national health insurance scheme regulation. So we can deliver a robust package of primary care, which focuses very much on maternal health, child health, malaria, HIV, TB, and so on, but can go a little further as well in terms of really being able to look after the family as much as possible. Just an overview of the schemes. We're running 4 schemes right now, 2 schemes in Kwara State. Kwara State is middle Nigeria. It's very arable middle Nigeria, so it's very much farming country. Part of it is extremely rural. Some of it is much more urbanized, but most of the work we're doing now is in the very rural parts of the state. And then we are running 2 programs as well in Lagos State, which is the commercial capital. And in a way, sometimes people say, why Lagos, where there is much more earning capacity. But we realized that, again, there was need for some catalytic sort of injection of subsidy and a program like this so that the awareness and the adoption of health insurance could grow. And that has been pretty important. Well, we've seen some challenges. Renewal has been one of the biggest challenges we've faced, making sure that we get the same people to sign on year after year. You'll find that apart from one of the programs where we're at over 70%, we're just under half the population renewing. And this is a key issue because it means that every year, half the people drop off. And then we have to sort of, again, go out and get more enrollees. Now, that's been critical, and I know that Jacques and the team have done quite a bit of operational research in this area of trying to really link what is it that makes people renew, without also creating too much of the adverse selection that you want to get away from in risk pooling. Because in most cases, people renew when they know they've been sick or when they know they're going to need the service. So it's how do you make sure that you don't, dilute your risk pool, but at the same time get the people, the healthy people into the system. Of course, the premiums have varied. We have premiums that are much lower in the rural areas than in the urban areas, just from the perspective of the cost of living. This just gives you some idea of the growth of the enrollee population. This gives you an idea of how much the communities participate in the exercise and how much they look forward to it. This is in terms of people waiting for care. One of the things that we saw, was the huge increase in utilization of services. Right now, we have over 600,000 hospital and clinic visits since the last 5 years. So that has been a huge increase in the utilization of healthcare services with the scheme. In terms of sex and age, certainly it is an overwhelmingly female population. On average, it's almost 60% of the population across all the programs who are women. And again, similarly, 13% are under 5. In fact, when you add the women and the under 5s, both male and female, we have about 2/3 of the scheme serving the women and the under 5s. As I mentioned, in terms of utilization, about 600,000 visits have been made, with almost 60% happening in Lagos. One of the things that has come up, again, has been described in earlier presentations today, has been the incidence or the prevalence rate of non-communicable diseases. This was one of the things that we could not have predicted for when we were doing the program and designed 5 years ago. Because 5 years ago, the numbers were only just beginning to show up. Prevalence rates in terms of disease profile was almost 70% between malaria, TB, and HIV. Malaria itself being about 50%. But today it's a very different picture, where we see malaria being less than 1/3, and in urban cities like Lagos, between hypertension and diabetes is now about 1/4. It's like 25% and above. And that has also posed some challenges, one in terms of increasing the cost of care, but also in terms of a challenge from the point of view of the skill base of the medical community themselves. And how do you sort of make sure that the primary health system is adequately skilled to be able to recognize and look after the patients? As I said, this is just showing you, the red line is showing you the chronic diseases, the fact that, and that what we're forecasting is that overall usage, the chronic diseases, which is the one in the middle, will be the one that will start to take up the numbers. This just shows you, as I mentioned before, the impact of the scheme and access to care on the utilization of the service itself. This is a case study of the Shonga Community Health Center, which was the first center that had proper intervention and a community around it that was insured in rural Kwara State. And just before the program started, they were seeing something in the region of 150 patients a month. And the numbers just climbed and climbed and climbed. And right now we're in a situation where they're seeing well over 1,000 patients every month, sometimes 2,000. And really, yes, it's tailed down, which you would expect because you hope that certain ailments would have been fixed by now, and which they are, but still very heavy, very healthy utilization of the system has occurred. This is just giving an idea of some of the upgrade work that's been done with the Health Insurance Fund and the Kwara State government themselves also taking an active part. Skills and capacity building, that's also been extremely important, as I mentioned, as we've also seen the change in the prevalence rates of the diseases and of the care requirements. There's had to be very focused training of the staff, of the medical staff. We've also focused training on quality, as well as on management skills. And I would like to say that the management skills part of the training has probably been one of the areas that has delivered the most impact to the professionals, especially to the small clinics who run their own businesses. And that's something that they have been extremely, extremely grateful for. And this is just some testimonials of an HIV-negative baby being born to HIV-positive parents through the successful prevention of mother-to-child transmission program that goes on within the scheme. And also another baby who was born and named Hygeia after being safely delivered, from an obstructed labor. So we're quite pleased to know that there are little children, walking around based on this scheme. But I just want to touch on quickly the advocacy impact of the scheme, because that's one of the key things that, was said this morning, the catalysm that programs like this can generate for local governments, for national public systems, public health systems. And we've definitely generated our own fair share. Ban Ki-moon, the UN Secretary General, was recently in Nigeria in May, and this was a key reference point for him of the work that was being done in this program. Similarly, the central government's Ministry of Health has developed their 5-year National Strategic Health Development Plan, and within it, the program again has received special mention as being one of the key ways of revitalizing the primary healthcare system. But what is probably most worthy of note is the fact that our National Health Insurance Scheme, which is the central government's regulatory and implementation framework for health insurance, has also adopted community health insurance using very much the methodology that we've seen as at least proving to create results over the last 5 years. They are now working very, very strongly with bringing, a collection of cooperatives or mutuals together, of beginning to galvanize the work and the discussion around subsidy, and to be able to make for sustainable schemes. And they are actually at the moment being very much supported by a piece of legislation that is going through the motions called the National Health Bill. It's the first time we're having a new health bill for, 30, 40 years. And one of the key things that the bill legislates for is for increased funding for health insurance and primary health care through community health schemes. And it's likely, the way the numbers stack up, that will bring another $2 billion of funding to the table. Yes, okay. And that piece of funding will be important because the whole vision and mission for this is achieving universal coverage, which I know is very much what the Netherlands and countries in this part of the world have been able to achieve. By looking at some very much back-of-the-envelope numbers of seeing what the care prevalence rates are now, having to now sort of begin to budget for the need to cover for non-communicable diseases as part of the primary and secondary care portfolio, we've looked at a per capita spend of about 42 euros, which is roughly $55, which is spot on with the WHO numbers for 2011. And that, given the size of our population, would come to a pretty significant health expenditure budget of $6 billion. But again, programs like this, galvanizing the federal government to be able to bring more money to the table would obviously be a key step in the right direction. And maybe I just wrap it up with the key learning points. As I said, community involvement is crucial, so that way the community owns it, lives with it, sees the benefit of it, and can definitely continue to contribute to the risk pool. Certainly marketing, because we realize that, the whole knowledge and appreciation of insurance is still a major hurdle that we have to overcome. Pricing, both in terms of really being able to understand what people have the ability and willingness to pay for, as well as being able to always reprice to reflect the disease prevalence of the population is key. The quality side and the monitoring and evaluation to ensure that the quality remains at the standard that the people will trust and buy into. And of course, the subsidy, which is also important, particularly for state and central governments to buy into. So I think that's where I'd like to leave it, but just to show that, yes, at least so far, we've seen very positive results from the program. Still a lot of work, still a long way to go in terms of its scale up, but clearly there's more than enough traction now, both with local government and other donors as well, to make this thing, what it needs to be. Thank you very much.